The first pain we will cover is the tendon. So pain in your tendon can be a few different things. It can be tendinopathy, can be apophysitis, I'm not sure how to say that. It could be tendon rupture. It could be a whole tendon pain. It could be tendon graft pain. And you could have been diagnosed with a partial tendon tear. So we're going to cover all of those. Those are 6 that I just listed. We'll start it off with tendinopathy. Tendinopathy, it's a disease or disorder of the tendon that causes pain. In the past, or I guess still to this day, people call it tendinitis, and the itis means that the pain is from inflammation, or they call it tendinosis, and the osis means that the pain is from degeneration. But tendon pain is still poorly understood. So you can't really call it you can't really call it tendinitis or tendinosis. It is safer to say tendinopathy, which just means that we don't know what's causing the pain, but there is pain. So when we look at tendinopathy, they occur at the antisis. This is where the tendon is hitting the bone. And there are only 3 spots this can happen at the front of the knee. It is above the kneecap, quadriceps tendinopathy is below the kneecap, patellar tendinopathy, and it's at the tibia, which is distal patellar tendinopathy. So those are 3 different areas of tendinopathy, but they're all part of the same tendon. They're all very similar. I'm going to talk about similarities and then just one difference towards the end. So here are these signs you should be thinking that your pain is a tendinopathy. So it's going to be pinpoint sharp pain that stays localized. It's a very small location. And when you do get pain, it's sharp pain. And that type of pain comes about in high tendon stress things like jumping, landing, changing direction, explosive lifting. Those all stress the patellar and quad tendon. One of the exceptions is prolonged sitting. So if you have to sit in a bus, a car, a plane, you can get the same type of tendon pain if you have to sit with your knees flexed. I'm not exactly sure the reason for that. So a couple more things that are common with tendons that you won't see with other things is you'll get a warm-up effect. So you can go into a session that's going to load your patellar and quad tendon a lot, and it can be very painful. But as you warm up, it gets better and better. The pain could completely go away and allow you to play. Then you will get a delayed pain response. So if that activity was bad for your patellar and quad tendon, if you weren't ready for it, you'll wake up the next day with more pain and stiffness. It could be in the morning or it could be the next 24 to 48 hours. So it is a delayed pain response. Why does this pain come about? The idea is that you have exceeded your tendon's capacity. So if you look at your training history, you could see, for example, that maybe for the last month, you've only played basketball once per week. And now in this week, you've played 5 times per week. So your tendon's capacity was at playing once per week. And now you gave it the stress of playing 5 times per week. You've exceeded your tendon's capacity. And tendons need a consistent stress on them to stay good. It's when you have those big changes in stress level that the pain is more likely to flare up. You can actually see that athletes in season who do very high tendon stress levels are usually pretty good. It's going to be when they go from not doing much to doing quite a bit that they get the blow up of tendon pain. So the only difference with these tendinopathies are the levels of knee flexion. So if you look at bending your knee from a straight leg to 60 degrees, that's going to load the patellar tendon a lot. When you go from 60 to 90 to 120 to very deep knee flexion, that's going to load the quadriceps tendon more. That is because as you get deeper and deeper, the kneecap slides down, so you're not going to stress the patellar tendon much as you get deeper, but you're going to be stretching the quad tendon more. So you can see what type of athletes might get the tendinopathies. If you look at patellar tendinopathy, it's going to be more common in athletes who spend more time in earlier knee flexion, for example, a basketball athlete, a soccer athlete, whereas quadriceps tendinopathy is going to be more common in athletes who get deeper levels of knee flexion. That would be like an Olympic weightlifter or a volleyball player. You could think of a volleyball player landing very deep. And if you look at distal patellar tendinopathy, that's actually common in distance runners, and I don't know the exact reason for that. So I just talked about all these signs and symptoms of tendinopathy. If those match up with your pain, that's what you are going to be thinking, that you have tendinopathy. Another issue with the tendon is apophysitis. I just lumped it into the tendon. It's not really a tendon issue because it's more involved with the growing centers around the tendon bone interface. This is going to be seen in kids. So you have two locations. Apparently, you don't have it above the patella, but you have it right below the patella, which is Sinding Larsen Johansson, same location as patellar tendinopathy, and you have it at the tibia, which is Osgood Schlatter. So the idea here is that it's going to look very similar to a tendinopathy. Pinpoint pain, high tendon stress things are more likely to provoke pain. They might get a warm-up effect. They might get the delayed pain response. And because this is in young kids, they don't know any better. They start to get that knee pain. They just rest, and then they feel a little better, so then they go stress themselves again. So it's these big changes in load going from not doing much to doing way too much where they really run into issues. Michael Rathleaf actually had a study where he put a graph where what kids do is not right, whereas they need to be educated on what to do with building themselves up based on their pain. So the apophysitis is an inflammation and a stress injury to those growing centers. This happens in kids that are around age 9 to 15 because those areas are still soft and cartilaginous. So they're actually the weak point in the muscle tendon bone chain, so they're more likely to get injured. And these are going to be seen in kids in sports, so you have to overload the knees to get this injury, which is pretty easy to do. Just play basketball, volleyball, football, whatever sports, kids can overload those areas. And something that you might see that can't really diagnose or confirm that they have it is, but it just looks like it. You see thickening. So there's an Osgood Schlatter bump where people will develop this growth on the tibia, tendon tibia area, and then you can get a similar thing at the Sinding Larsen Johansson area. Not that it really matters, but it's just something you'll see. So if all these ideas line up with the pain that a young kid is experiencing, then you're going to be thinking Osgood Schlatter or Sinding Larsen Johansson, the apophysitis injuries. We're going to talk about the last four that I talked about. Just briefly. So you can have a tendon rupture. This can be the quad tendon, can be the patellar tendon. I think it's more seen in older males. You just have an event happen where you rupture them, or you rupture one of them, the patellar or the quad tendon. And you can get this, you can know, or I guess you can get it picked up on an MRI, you can get it picked up on an ultrasound. Pretty easy to figure out that that's what happened. And then you could get a whole tendon pain. So I talked about tendinopathy happening at the enthesis, but you can actually get a tendon pain not at the enthesis, which would be kind of in the middle of the tendon. And that is usually going to be the result of a direct blow to that area or a fall on that area. And if you look at a tendon, it's pretty close to the skin. It's not a very deep structure, so it can be prone to getting those direct hits on it. And that's not going to have the characteristics of a tendinopathy. It's just going to be like an area that is very tender and sore depending on how hard you got hit. And you can also get a tendon graft pain. So they can take your patellar or your quad tendon and replace a ligament like your ACL or even ones in your upper body. And the consensus seems to be that you treat it just like a tendinopathy. It can just take a long time to heal, like 6 to 12 months. The last part about tendon pain, anterior knee pain, tendon pain I'm going to talk about is partial tendon tears. So this is a pretty debated topic that you will get the partial tendon tear diagnosis from getting an MRI, maybe getting an ultrasound, but it seems to be more common getting an MRI. MRI gives you a 3D image. Ultrasound will give you 2D. It's debated because you can image a healthy tendon and know for sure that it's healthy, and then you can image a tendon rupture and know for sure that it's ruptured, but it's the middle ground that's difficult. How do you know that there's a partial tendon tear or if it's just a tendinopathy? So one of the experts on imaging is Sean Docking, and he was on a podcast where he was saying it's very difficult to diagnose a partial tear. It's pretty much a flip of a coin, 50% whether you know that it is a partial tendon tear or if it is just a tendinopathy. And because you can't reliably distinguish between the two, it's probably safer just to say someone has tendinopathy. Because if you tell them they have a partial tear, I actually got diagnosed with a partial tear. I believed that I needed surgery and nothing else was going to help. But if you just tell someone they have tendinopathy, it's probably a lot safer that they might feel better about getting on a loading program to help them. The tendon tear story might work when you ask how the injury happened. So if someone had a cut or jump or land where they felt a pop in their tendon, but it wasn't a complete tear. That might be a situation where there might have been a partial tear. Again, does it matter? Should you say partial tear? Should you say tendinopathy? It's probably safer to say tendinopathy at this point because there are no good guidelines to say whether someone has a partial tear or not. And telling someone they have tendinopathy is going to probably be a lot better case to create a lot less fear for that person. So this entire section was on the tendon, anterior knee pain, looking at the tendon, not necessarily as the pain generator, because the structure is not always the pain generator, but these are going to be things that you are looking at for if tendon is provoking your pain. And next, we are going to go on to the patellofemoral joint.